Let's do it. I think you're starting.
Yes, I am. Okay. Hi, everybody. My name is Rosemary Hannum. I am the director of the Sandra Rotman Center for Health Sector Strategy here at the school, and very pleased to welcome you to tonight's panel event, Digital Health Startups, the 2022 edition. Although this event is taking place virtually, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, while we are meeting virtually, Toronto is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So hello, everyone, and welcome to the third event in our Health IT series this year. We have a terrific panel lined up for you tonight. 4 entrepreneurs who are leading startups in the health sector, and we promise a very lively discussion tonight, as always with Will, learning all about their companies, how they got started, as well as their strategies for success and learning along the way. Our host and moderator tonight is Will Falk. Will is a senior fellow at the C.D. Howe Institute, and he is also an executive in residence with us here at Rotman. He serves as a board director at Verdo Health and FirstHx, and he's also an innovation fellow at Women's College and a senior advisor with Satov Consultants. So before I hand it over to Will, just a word about our center. We are supported by the school and the Rotman family, and we focus on 3 main areas: research and thought leadership, educational programming for emerging leaders and senior leaders, and outreach activities like this one, which we design on behalf of our students pursuing careers in healthcare management. Follow us on LinkedIn if you haven't already for the latest in our research, our programming, and our events. And yeah, okay, so now over to you, Will.
Okay, thanks, Rosemary, and thanks for everything that you do getting this to happen. This is the third in the series of 4. I put the Twitter hashtag in the chat if people prefer to comment on Twitter, and you're of course welcome to heckle any of us in the chat as well, but you can't heckle us directly because Zoom controls that, and so that's too bad for you. But the 6 of us will be on screen, and okay, so we always do 4 topics. Most years we change up the other 3 topics, but this one is the one we've always done. Last year we did IPO'd companies, or companies that were public, but that was a bit of a change, but in prior years, we've always had founders and CEOs come on. This year, we've got a terrific group of 4. We have over the years, most of the companies have been early stage or even often pre-revenue, but the current market cap of the companies that have come in that state as early startups is now well over $2 billion. So we've had some pretty impressive folks come through, and I think I've got some great hopes for each of the 4 that you're going to hear about today. The format's pretty straightforward. We're going to let each of the 4 of them introduce themselves. We'll go in alphabetical order, meaning Bill, Sam, Alex, and Chris. And then we will have a group discussion. The first presentation is a bit of a pitch, and I don't think I have anything else to say. So Bill Cherniak, over to you.
Great, thanks so much. And just to everyone, a quick apology if the internet quality is not the best, or you hear or see people behind me. I'm currently in Iquitos, a town in the northern region of Peru on the Amazon River with my nonprofit, Bridge to Health, Medical, and Dental. And so I hope the Wi-Fi is strong enough for this to work today. But I'm just going to share a couple of slides. And so I'm here to talk to you about myself and also about Rocket Doctor. And I wanted to start with a few statistics, actually. So the top number, 14.5%, is roughly, according to StatsCan, the percentage of Canadians above age 12 that are unable to access a regular primary care provider. Around 6.1 million people are the number of folks across Canada that live in rural or underserved communities. And 112,000 is the number of Canadians that we've been able to provide care to at Rocket Doctor since we launched just 18 months ago. And so for my background, I'm an emergency physician, also certified in family practice. I went back to school after finishing my residency and moved to the States, went to Baltimore, did a master's of public health at Johns Hopkins. And I'm going to tell you a little bit about my background as you sort of frame the context of how Rocket Doctor came to be and what we're all about. But from there, went to Washington, D.C. and did a global cancer research fellowship at the NIH, the Center for Global Health at the National Cancer Institute, and then moved to Los Angeles and was teaching in the Master's of Science in Global Medicine program while also teaching here at University of here in KeyOps there in Toronto in the Faculty of Medicine, Department of Family Community Medicine. And so was taking groups of students overseas to East Africa and currently teach a course here at Johns Hopkins on global health entrepreneurship. And we'll sort of touch on this a little bit, I think, around being a physician, founder, and CEO of a company. But one of the reasons that I got into this space is actually my first startup wasn't Rocket Doctor. It was a nonprofit called Bridge to Health Medical and Dental. And our mission is to partner with government, civil society, academia in low resource settings to help them build comprehensive care for rural and underserved communities. And through working with Bridge to Health, got engaged in a high-tech diagnostics. So that's actually a picture of me in rural Uganda on the right side of the screen, teaching mid-level providers and working with them on a really cool device called the Butterfly IQ and setting up a point-of-care ultrasound program with a cloud-based teleradiology system. And it was through that work that we caught the attention of the New York Times and ended up with a cover story in the spring of 2019 that was retweeted by Melinda Gates and really got me more into the kind of technology space and thinking, how do we pair advanced diagnostics with virtual care in order to actually expand the capacity of what we can do at home in Canada? And so I was working a busy flu season in the fall of 2019 and just tons of kids coming in with cough, cold, fever to the department who really didn't need to be there, could have been treated effectively at home. And, was thinking if we could pair advanced tech, we could hopefully identify the 3 in 100 kids that are sick, bring them into emergency departments for care, keep the other 97 at home and save the system a bundle of money, parents and their children, an unnecessary visit to the ER. So, started to conceive the company and then the pandemic hit. And all of a sudden, governments across Canada, and in some cases there were these before, and previously we had examples of it in the first outbreak of SARS, but Government of Ontario released publicly funded virtual care billing codes and went, oh, wow, we have this great opportunity now to provide care to all folks in all parts of the country, even if you're in a rural underserved area or you might otherwise lack access to care. And so, since we launched, again, we've seen more than 100,000 patients, have more than 300 physicians working with us, and more than 50 of them are in specialty care. And our aim, again, is how do we provide comprehensive virtual care so that folks actually can access everything they need under one roof. And our model, being a physician as well, is that we don't look at doctors as our employees or contractors, but rather how do they engage with us as customers to use our technology to then run their own virtual care practice and provide services to Canadians free of charge using their provincial health insurance. So part of the question was advice for maybe MBAs that want to get involved and engaged. I think we'll probably talk about it more with the panel. My time's running up, but the idea road also is that paths can be a little meandering, and one thing can lead to another, and working on a project can get you connected with someone who gets you connected with someone who then gives you an idea that morphs into something, and just start getting involved with different kinds of initiatives and folks that you can work with, even if it's unpaid at the beginning or a lower wage, so that you gain experience and start to work in the space. But I think that's where I'll stop for now.
And Bill, is Rocket Doctor 100% in the public sector, public pay space, or do you also have a private pay product?
So we have for folks that want to do that. In Canada, if you have provincial health insurance, you don't pay for whatever reason, then we would offer them to pay out of pocket. But this physician, everyone that has provincial insurance can use it.
Super. Let's go to Sam.
Thank you. Hard to follow that one, Bill. Thanks. Very impressive. So I'll start off. I'll tell you a little bit about my journey and sort of how that leads to where we are today, and especially with KeyOps. So I'm a gastroenterologist practicing out of St. Joe's in Toronto. During my training, I took a couple years where I did my MBA at Rotman, and I paired that with the clinician investigator program. It took a few years to really get my feet stable in my practice before, I started branching off. But once I did that, I started to venture into like my other passions. So that's entrepreneurship and health tech. So me and a few colleagues started Halo Health, which is Canada's first angel group of physicians. So we started working with health tech companies and investing in different companies. Got involved with a few, an advisor to Iterative Scopes down in Boston, who's made a big raise recently. So that's been really exciting. But then, I partnered up with my colleague. He's a cardiologist, Saeed Darvish, and we started KeyOps. So the way we sort of came up with this idea, and I'll just share my screen. So the way we came up with this idea, me and my colleagues typically think about what are things that we do in our day-to-day as physicians that if you look back in time in the future, you're going to say, I can't believe we used to do it that way. The analogy I give is when I was a kid, I used to sit at the back of a station wagon, no seatbelts, running around the back, falling all over the place as my parents made turns, waving at people. If you saw that today, you'd probably call the police and report dangerous driving or child endangerment. But looking back, that's crazy. So the same applies. So in health, in my space, everything that physicians and industry do is engagement. So like dinner meetings, advisory boards, which are these 3-hour sessions where you go to a conference center and you hear talks and you speak to your colleagues, and lots of different things like surveys, phone calls, visits in the middle of your day to your office when you have a very busy practice. All those things we're thinking. There's no, this is crazy. This is being done the same way it's been done for probably 50 or 60 years. What if we applied technology and cleaned up a lot of the issues, made it sort of the way that physicians wanted, more condensed, apply technology. So we have a proprietary platform where you can actually do all these engagements on the go in really condensed format, and it's arm's length, and a lot of it becomes blinded. And we started this, me and my colleague, a couple of years ago, and it really caught on. A lot of our colleagues really enjoyed it, and we have a really good response rate, and we started growing. It was a really busy week in the past 2 weeks. We launched in the US, and we ended up bringing on 4 times the number of physicians we were expecting. So we actually had to shut down our onboarding because it was going so well. And now we have physicians across the US part of our platform. So, I know my time's running low. To really build this out, we had to really build the team out as well. So we have we hired a CEO and a chief commercial officer, also a VP of our business development, Curtis Fickner, who's not on the slide, who's been very instrumental as well, and Megan Mahaboub, who's an MBA grad from Rotman. She started off as an intern, full-time right now, and she just went on her mat leave, again, instrumental. So it was really building out the team that made us a success. So right now we're in our the midst of starting up our raise. And we're going to probably have a lot of opportunity for more hires. I think part of the discussion as well is what else could MBA grads be doing to get involved. At KeyOps, definitely we're going to be hiring more people. So always exciting to bring on new smart people to the team. The other thing is with Halo Health, if you're interested in health tech startups, in working on raises, there is a program where they bring on fellows to help with vetting or doing the due diligence, and you get a lot of experience that way. So, feel free, you can always reach out to me. I think we're going to chat a bit more throughout the rest of this talk, and I'll stop there.
Hey, do you, Sam, do you guys publish, oh, I'm sorry, my video's off. Do you guys publish the kinds of topics you're commenting on? And also a Halo Health question, are you, is there a list somewhere of what Halo Health Angels are into?
Yeah, so sorry, you were breaking up on the first part, but I think you were saying, do we publish some of the data from KeyOps? Yeah. So any KeyOps-led engagements, we share the data. So we just launched a project in the US on C. difficile. We'll be sharing that in the next week or two, some of the results, and lots of interesting things that we feed out. Things that are proprietary from the companies, will share whatever we can with the members who participated. But if it's not our data, we can't really share that publicly. The second question about Halo Health, if you go to the website, you'll see some of the companies that that were successfully invested in. And I think it really runs the range of, health tech. I think probably one area that's not very strong is, biotech, but, we definitely see all different pitches.
So just one more Halo Health question. If I'm going out for a round and it's an early round and I want to open it up to Halo Health physicians, I just contact you and tell you the pricing and the terms and the minimum investment, or how does it work?
Yeah, so we have a director, Luke Sheen. Because of KeyOps, I've stepped off of the board, so I'm more of a member of it right now.
Yeah,
but
okay.
Luke Sheen, who's excellent, you reach out to him. They have a whole onboarding process. They take all your information, an analyst goes through your data and puts it together in a data room, and then you get to pitch. Yeah.
Okay, Alex, you're up.
Great. I'm not a doctor. I'm a lawyer by training, and I built most of my career in the public sector, including 8 in government and 5 of those as the Premier's Director of Policy, where I touched on a lot of issues, including health. About 3 years ago, when I had a choice to jump into a number of things and I was approaching 50, I thought, what do I want to do? And I said, I want to write a book and build a business. So I went about doing both those things and published my first book last May. And launched 360 with our prototype clinic in Ottawa, September 2020. So we're just over a year and a bit in. 360 really came out of a conversation with me and my brother-in-law, who is a wonderful human being and a ER pediatric physician and a world-leading concussion researcher. He led the biggest pediatric concussion study in the world 5 or 6 years ago, looking at 3,000 kids, which fundamentally transformed the way we were approaching concussion care for kids. And he also led the global team that developed the international guidelines for any doctor, parent, or coach anywhere in the world to have an appropriate triage to, diagnose concussion. I said to him one day, hey, hotshot, you're clearly a superstar researcher. How come no one I know can get proper concussion care? And through that, we started to look at what we felt the problem was. I didn't think that the public sector was going to make the kinds of investments through public health to solve the problem. And so we started to look at the problem with a view to diagnosing solution. A huge amount of awareness around concussion. About 1% of the Canadian population a year gets a concussion. People get diagnosed, but there are very limited evidence-based quality options for people to access care. So he and I started to say, so if we were to look at this and become more involved here, what would that look like? And we felt like if we developed a clinical model that delivered evidence-based, multidisciplinary physician-led care consistently, so anywhere you set up a clinic, patients having a consistent experience, and really focus on making it accessible, that would be a huge step forward. But what got us really excited is realizing if we start from scratch, we can set this up as a learning health system. We could build the biggest concussion patient registry in the world and really continue to drive incredibly cutting edge research. That got us really engaged in committing to set this up. We then went out and built a really phenomenal leadership team. We brought in an adult specialist from Buffalo, John Letty, who's developed some of the signature treatments for pro athletes and for adults, and then rounded out the team with a number of people, including my sister, who's a superb GP, because we wanted the GP perspective in this. We set out to craft mission, vision, values that are both mission focused and entrepreneurial. There's a public-private component to what we do. All of the doctor care that we provide is covered by OHIP, but there's an allied health component that's private pay, and those things work hand in hand. Our objective really is to build a sustainable, profitable clinic model, but the learning health system is a public good, and we are constantly developing and sharing those learnings with people in a collaborative way. We are, as I said, both, there's a public component, OHIP, and a private component with private pay. But the learning health system for us has been a huge part of what we've done. We've set up a clinical model that is delivering excellent care. That learning health system has taken a huge amount of time, investment, and effort over a year and a half, configuring systems very deeply to constantly capture learning and convert that into a research and knowledge translation products. Everyone who comes in for care in our model is part of ongoing research. and we're working collaboratively with leading hospitals and universities around the world to turn that into evidence-based action on a continuous basis. I thought about a few highlights just to share quickly. COVID for me was a significant highlight. It has been challenging in a way that's hard to describe. The only thing that can really impact rates of concussion are when people do not leave their home and do no sports and activities. And we had modeled for that at the outset because of when we were launching. What we couldn't anticipate is the impact on so many other things, people's mental health, you know, how your staff is managing through something like this. But what it did is it changed our model. So 75% of what we do is virtual, 25% in person. And without COVID, we would have started with the opposite. And it would have taken a lot to unwind our systems and move to where the world is going, which is a much more virtual world. We've had 2,000 referrals in just over a year, and we've done most of that at times when people have been locked in. So that referral piece and that quality piece and that brand building piece is there. Our target audience is not patients, it's doctors. We're really focused on building that relationship with doctors as referrers, so they see and understand the quality that we're bringing to this. We've grown from 1 full-time person when we opened and 5 part-time people to 8 full-time people and about 25 part-time people. And I've done this with family members, which has been a really unique experience. I wouldn't have imagined going into business with my brother-in-law. While I love him dearly, we're very different people. Or my sister, who's one of my closest friends, but it's been a real joy and an incredible experience doing it with them, and tons of learnings there. We've got a clinic in Ottawa. We expanded into Toronto this fall. We've got 1 clinic and we're focused on opening up Mississauga soon. And we're really trying to build a model that we could replicate in any market, in any part of the world that delivers high quality, evidence-based, physician-led multidisciplinary care at a consistently high level, and develops incredible research that we can convert into best practices and learnings along the way.
Alex, are there other concussion care models that are out there that you're bumping into and competing with, and what does the market look like across North America at the moment?
What we're doing is not rocket science, but it's pretty unique. To do it well, consistently, and deliver a quality product so that anywhere a patient has a similar experience is unique. There's a ton of care out there. We defined this as a Wild West when we got into it. People are taking weekend courses and on Monday saying, I'm a concussion specialist. It's your brain. So you're dealing with a mild traumatic brain injury. For us, that's not an appropriate pathway to great quality care. Increasingly, people are working in multidisciplinary models. The big difference for us is it's physician-led. You can't walk in and see a physio. You can't walk in and see an occupational therapist or mental health specialist. You see the doctor, and then you work with a team. And our objective is to get you out as safely and quickly as possible. That doesn't exist, broadly speaking, frankly, anywhere. So we look at this as a model that could be parked down in Canada, in Germany, in Australia, in China. The world needs great concussion care. We want to deliver it efficiently, we want to deliver it effectively, and we want to have a profitable business model that has a public good component embedded in it through the research, and both of those go hand in hand.
Chris, you're up.
Thanks for that, Will. It's quite a group to follow, to say the least. So quickly, my story, I'm a practicing critical care physician. I still practice critical care out at Trillium Health Partners out in Mississauga. And I guess my sort of entrepreneurial journey begins in the early zeros out at Trillium when I was just starting out. And for my patients to get all the things they needed, they had to be all the drugs and investigations, they had to be ordered. I had to do it from memory, from scratch. I thought that was a lot of work and prone to error. So I had this idea of, what if I had checklists to do this? And that led to me founding Think Research in 2006 as a way of getting these knowledge-based checklists out to scale. I was the president and founder of Think and saw it grow up to just over 200 employees, expand into 8 countries, including Iceland, Ireland, Saudi Arabia, the Emirates, United States. It was exciting to see it grow. And then ended up with Think going public at the end of 2020. And so at that point in time, I thought it was time for me to move on and pursue other challenges. And so it was after that, shortly thereafter, that I got a call from Mark Benoria, who's a nephrologist in Kitchener-Waterloo, and Roman Ellenson, who's a primary care physician, specializes in pain medicine. And they brought to my attention that they've been working on an application to take histories from patients. The problem that bothered them, and this started way back in medical school, was that the way that physicians and other healthcare practitioners, learn about their patients is they take a history, and it's a completely unautomated process. It's a free text, unstructured interview. They built a computer application that would interview the patient before the provider saw the patient, so that when you actually did see the patient, you had a report. So as a physician, I immediately got the value prop, like, this is way cool. It would save me time. It'd make me a better doctor. I'd be less likely to forget stuff, because if you forget stuff, I could use it for documentation. Nobody likes to document stuff. So signed up as the CEO in February, and was having a great time growing it, when I noticed something a little unexpected, was that it wasn't just the physicians and nurse practitioners who liked it, but the patients loved it. The comments from patients were over the top, really, really positive. And then, I never really thought about the patient side of the interview process, but it doesn't serve them well either. Big literature, patients are cut off, don't get their stories heard. And so we realized what it was actually a patient empowerment platform. And so we've pivoted towards that. And then sort of what I've spent my time doing sort of the last year is building the foundation for a scalable business. Just having a super cool application that takes great history is not a business. You need all the things to support it, all the sales and finance and HR and legal. You have to build an infrastructure. So we've been building that for the organization. And then the other key thing that you need as we've been growing is you need great people. We have 2 Rotman alumni who have joined the team. Prashant Falford, who's amazing, who's a merged physician working with us. Lachlan Holmes is our CTO and leading up our tech team growth. We have Beth Jarrettson. She comes out of U of T informatics. She's been phenomenal. She's responsible for our expansion into cancer screening. So we've been building.
Also a Rotman student, Chris. Also a Rotman student.
Also a Rotman. Sorry about that. Okay. So 3 Rotman alumni.
Okay.
And it's been great working with all of them and growing out the team. And so where we're at right now is we have a robust sales pipeline. We have opportunities in the United States, Canada, the United Kingdom, and in the Middle East as well too, in the United Arab Emirates and Saudi Arabia. We've hired a VP of Middle East operations who's driving our expansion there. And what's super cool about it is really applicable. People take histories everywhere healthcare is delivered. And so we think the opportunity here is really significant, both in terms of growing as it currently is, but we also see the opportunity for innovation and development from where we are now. It's just a hugely exciting time. So super excited and looking forward to growing. So, and I would also echo what people have said. We are looking for good people, and for people who are interested, definitely reach out, because there's a lot to do. Thanks.
And Chris, it's cool to see, and it occurs to me listening to you, you were a physician founder, but now you're the hired management, right? Like you've come in as the hired management. What's the difference? Like, how does that feel relative to being a physician founder? What's it like to come into someone else's company and even though you are a physician, you are the management this time?
Yes.
Is it different?
Not really. Yes and no. In a way, it's better. Like, whether you want to, it's way better to come into something that's already in progress, has been developed, that you've gone through. They've been done years of product development. So they spend lots of time in the wilderness doing all of that work. And it's great to come into something where that's already been taken care of, rather than walking down that road yourself. So they both have their pros and their cons. It's nice to build and develop sort of your own idea, but it's also great. The thing that different people like different things, but I like working with smart people, solving interesting problems, working together. And so to join a team that's already sort of in progress doing that was really fabulous. I really like that. And
Sam, I'm going to go to you on this. What's it like doing your second startup as a as a founder, and do you guys have a support group that I don't know about
Yeah,
for
no,
physician founders?
No, so you know, to be honest, the support group I have are, you know, almost that the Halo Health group that we built Halo Health together, and you know, many of us have our own startup, so it's almost like our small community where we learn from each other and help each other out. Now, I think definitely with KeyOps, it's been really exciting watching an idea like I was telling you, which was, you know, we're having a beer and brainstorming what would be crazy if we could disrupt this, and then turning into where we have, you know, over 1,000 doctors and huge pharma companies, and we're pumping out lots of data, and it's just amazing to watch it actually happen in real life. So it's definitely been exciting the second time around. I don't think it grows old, taking an idea from just a discussion like Halo Health was. We used to get together for dinners once a month, a group of friends, and tell each other what we're working on or who we've spoken to, and then we formalized it. So I think it's been, you know, each time seems to be exciting.
So that's kind of neat, the idea that you can share and see where different people are. I mean, there are a whole bunch of good angel groups that do that in non-physician communities, but I guess there's some advantage around talking through clinical practice areas. Alex, you've been dealing with this on the other side, managing, herding the cats and trying to get them going in the same direction. Any insights in terms of managing physicians as a non-physician founder?
Oh, I could write an entire book about managing physicians. God bless them. You save lives. You are extraordinary people. You are not easy to manage. It's not simply physicians. It's the whole team. We crafted mission, vision, values. It was really important to have alignment around those things. And the one thing that has been consistent throughout, which I think has gotten us from the beginning of COVID to where we are in a decent place, is excellence breeds excellence. So we started with a phenomenal leadership team. And as we brought people on, there's something different about the kind of person who's coming to work with us. They're really good at what they do, but they're kind of excited to do something entrepreneurial. And they're really excited to do something that also has a mission focus. Herding cats is not a bad expression. You know, it's really been finding alignment, and physicians are one part of that. But physicians, to me, are independent contractors working in a really complicated, often bureaucratic, slow-moving system. So on the one hand, that breeds some challenges. On the other hand, they want to get things done. And so we're creating a model where they can get things done. They can do really great work. And they're gravitating to that, which has been kind of evident in how we've been able to move forward.
I'm going to throw the cat herding video in the chat at some point for anyone who hasn't seen it. It's the old EDS one. It's amazing. But that is great. Can I switch topics? And I'm going to start with Bill and Alex again, if I can. I want to dig in a little bit on the reimbursement issue. How you guys are thinking about, so Bill, how you're thinking about balancing the two different types of reimbursement and building out a business model that works. And then Alex, I've got a secondary question on this for you in your old role as a political advisor or policy advisor. But Bill?
Yeah, I'm happy to give my thoughts. So I don't think it's any sort of secret that most virtual care companies operate on a model of a sort of split with physicians, sort of like an overhead that you would have in a walk-in clinic. Although our position is quite different from every other virtual care company really that I've ever seen, which is that we have built into our tech system the ability for doctors to utilize their own provincial billing number. They can then, using their own independent billing number, we don't have a group billing number, we don't tell them how to bill, we don't monitor that or track it or whatever else. We don't pay the doctors, we work as we would normally in the system, but then Rocket Doctor is able to see what they've billed, and then we inform them that, we have an agreement where we take a percentage of overhead from that. And so, doctors, as sort of Alex alluded to, we're tough customers to work with. We look at physicians as our customers, and so we're very driven by the docs, and folks are willing to pay us because they see huge value in what we're doing, because patients are satisfied, because we, really focus on how do we empower a physician to, provide all the tools necessary to run the best possible practice. There are services that are not insured currently across provinces in Canada, which I hope to see funding that comes through over time. Some of those things, include extra coverage and funding for evening shifts, for weekend shifts. Currently we're reimbursed. Like if I work an ER shift, you're paid, 75% more to work on the weekend. We don't do that for virtual care, so doctors don't want to work on weekends, which is unfortunate because that's when patients need to be seen. And so they go to the Emerge and spend 10 times the amount of money. And, in the US, unfortunately, we're about 10 years behind them, 20 years in some cases in digital health. They've had remote patient monitoring billing codes for some time where you can have analysis at home of blood pressure readings, oxygen saturation, no Bluetooth stethoscope. We have nothing like that. And so if folks want that, they have to pay out of pocket as a patient. So that's sort of, I guess, a high level approach, if that helps.
Yeah. And Alex, you're pretty committed to the Canadian healthcare system as a person. I know that over the years, and you're in a situation now where to build an excellent concussion care system, you're having to access private reimbursement. How's that? What would you say to your former self as a liberal policy or a policy advisor in a liberal administration? What would you, if you were meeting with your former self from 12, 15 years ago, what would you say to yourself? If you were talking to the equivalent in the Trudeau government about how we should be managing the system. That's kind of two questions in one.
Yeah, so when I came into government in 2003, the healthcare budget was going up 8% a year. And we realized within a certain period of time, it would overtake the budget. So no money for post-secondary, no money for community safety, no money for infrastructure. And it was a horrifying proposition. Strengthening public healthcare is hugely important. Having public healthcare is hugely important. The only way you can do a lot of it is what these folks are doing. You have to innovate, you have to create. You can build some of that into the public health system, but you can't do a lot of that innovation inside the system. It's not set up for that and designed for that. We did not embrace it. So much of, I think we did. We talk about innovation, we talk about those things. You have to have people who truly understand. You have to have people like these physicians who are not just physicians and get that part of it, but are entrepreneurs and get that part of it. And both those things have to go hand in hand.
But are you willing to say now to former Liberal colleagues or to your former Liberal colleagues that this is something we have to rethink? I guess I'm asking you, do you think that's something that Liberals need to rethink?
I don't believe in two parallel systems. I really believe you need a strong, universally accessible healthcare system, period. What we're trying to do is take a model that's not going to be solved in public healthcare. The government's not investing a lot more money in concussion, period. They've got bigger fish to fry. So if we can create a model outside of public healthcare that does a lot of what government would want us to do, great. And if those learnings can then support better care within that system, great. And if we're delivering research and knowledge translation products that the public system can't deliver and people benefit from that, it's a win-win-win for everyone. There is, and we talked about this a little bit in our prep call, there is a sort of bad smell to a private component. What we're doing with Allied Health is simply getting great physio, great OT, great mental health support that people would access regardless. And there's a public component as well. We have to get over that. We have to get over that struggle. There is going to be an element of private delivery in healthcare, period. Make sure that universally accessible healthcare is our core, but there's going to be lots of pieces around that we've got to strengthen. And government has to do as much as they can to have the right people providing the right advice and making good decisions to support the kind of innovation that this group is doing.
So I agree with that. I'm going to go to Sam and Chris on this topic. Guys, my question is, do we run a risk here as we innovate of creating an an in the bundle or an in OHIP system that is less innovative than an out of OHIP system? And how do we address that? And Sam and Chris, I'm going to let either of you jump in on that.
You can go ahead, Chris. I can follow up on you.
Okay, thanks. It's a bit of a I think the best innovations, and I'm wearing a little bit of my first history hat here, really work on both sides of the fence. You know, things that, I mean, the key thing is you have to save time. I think in the healthcare IT space, you got to save people time. You have to make their life easier. And you also have to improve quality and save money. Really, if you want it to scale, I mean, those are the attributes of the thing that you need to do. Things that improve quality but are harder to do inherently, which is true of a lot of quality initiatives, don't scale that well. And so if you build something that actually saves time and improves quality, that's going to work should work on both sides of the fence. And I think those are the kinds of innovations that we would like to focus on to mitigate the situation that you're alluding to, Will.
Yeah. Sam, you want in on this?
Yeah, I'll just follow up as well. You know, it's unrelated to my startup, but I'm a practicing physician. And I think it goes along with what the opportunity that Bill has taken and really run with. But, you know, it just took COVID for the government to realize, like, maybe we should fund some sort of virtual care. You know, in my practice, extremely busy gastroenterologist, my secretaries will, 10 patients a day will call and have a whole bunch of different questions. So at the end of the day, just trying to be a good physician, I call these people back. It's fine. That's part of my job, what I do, but that's not remunerated. Like that's your volunteer work at that time, just to take care of your patients. And, you know, that's like a disincentive for some people, especially when you're juggling lots of different hats. So it takes also the government to step up. You know, they've created these temporary codes for us to be able to do these virtual care and call patients back or do video chats. But right now that's, temporary. I'm hoping that the government steps up, makes that very permanent, and, also makes it that they don't disincentivize this as well. You know, maybe this is not a little controversial to say, but if they all of a sudden make the payment where I speak to a patient on virtual care over the phone worth 20% of me seeing them in person, you can't run a practice that way. You're going to end up having to bring everybody back into the office. So, we definitely need the government to step up in making sure that they not only fund this innovation, but also fund it appropriately.
Okay, let's turn to the other type of funding for a moment. I know that several of you are raising at the moment. I'm watching the companies that IPO'd last year. The values are maybe less now than they were a year ago. How Bill, I'm going to you first. Sorry. I'm wondering, how's the market? How's the valuation market going, and what's it feel like?
Put me in the hot seat first. That's fine.
Yeah.
And certainly, I think going to the market, everyone is very cognizant of what's happened to publicly traded virtual care companies, and I think the reason we're seeing that is because at the start of the pandemic, in particular on the US side of the border, because we have operations in California as well, and we have fundraised from American VCs, which is unfortunate, because actually it's a different topic about the Canadian venture funding landscape, that it's very, doesn't foster the kind of innovation that I think it could by branching out more broadly. But we have raised from US company VCs, and even then, the model was, let's spend, in digital health companies, I think it was, let's spend a ton of money. Let's bring a bunch of patients into our platform. We don't know how we're going to get revenue from them, but we'll figure it out later, and almost like an e-commerce social media approach. And then folks took a look at it and went, oh, Teladoc's got X million people, but got 4% utilization. And so we saw stocks drop in half or by 2/3 over the last year in Canadian publicly traded digital health companies. So our model has been, okay, how do we do the right thing for patients, which is provide digital tools to empower longitudinal care, while also having a sustainable business model at the same time that works on the lower reimbursement rates in the public system. So I think by having that approach, folks that are looking at funding us in a venture perspective see the utility and value of that, where we're not just saying we're going to pour a ton of capital in and not figure out how to make it back. Ultimately, we want to run a viable business. Hopefully that's helpful.
Sam, you look at this as on both sides because you're also an angel. What are you thinking?
Yeah, I think it's from the valuation standpoint, I think it's still pretty frothy, to be honest, what I'm seeing, and a lot of the deals that are closing, the amount of money, I'm an advisor to Iterative Scopes. They just raised $150 million. And that was like a couple months after they raised 30 million, so then that's in the US, and I agree with what Bill was saying. I think the US is a little bit different than in Canada. I think we're a little bit more reserved here. So definitely the deals, there's a lot of deals out there. It still seems to be pretty frothy. We're going into our raise now. I guess we're going to find out what, with the offers come through. So hopefully everything goes really well. But, and I think this is also where probably people are a little bit more discerning about the startups to really look at, how much revenue are these, if they're pre-revenue, it's a little bit different. Like, what is the revenue? What's, are they creating ARR? What's the pathway to success here? So, and I can just say from our journey, people are really pushing on that. And, that's something that we focus a lot on. So, I think even as an investor myself, I really try to understand that from some of the startups and not just sort of jump on ideas. I want to see sort of some progress from that standpoint.
Hey, there's a question in the chat that I'm just going to pull forward. A couple of questions in the chat I'm going to pull forward. One is this issue of in-person location. I don't know who wants to take this, but I guess, Alex, do you have in-person locations always, or do you have a virtual only offering as well?
We will have in-person period. We actually pioneered with our inaugural neurologist a virtual model. She's a superstar, and she had 2 young kids, a 6-month-old and a 2-year-old at the beginning of COVID. And she said, if I sign up, I need to do this virtually. And we said, not optimal, but we're going to make it work. She's a star. It's a phenomenal model. But we will always push very hard our model to have an in-person component. That initial assessment should be done in person. It's best for the physician, it's best for the allied health, and it's best for the patient. If it can't be, then we would facilitate virtual, but not because someone doesn't want to drive an hour. We're going to push hard for that initial, but we are now pioneering models because of necessity with someone like this wonderful, super talented young woman. And we could probably validate that her exam and the outcomes are as good with what she's doing as our in-person. Both will be important, but and
you're subject to provincial regulations and licensing, so fair to assume that you won't be in Newfoundland anytime soon?
No, we're talking with Halifax, we're talking with Quebec. I'll just say one of the first things we did as a leadership team is developed a virtual concussion exam for GPs to support them in diagnosing concussion through COVID. So that's now part of the international guidelines. It's just been included in that. And we said in-person is optimal, but virtual is the way of the future and needs to be a part of delivering great concussion care. And so we really led that charge.
I go back and forth on this one a bit, guys, because, and I don't know who else wants in on this, but I go back and forth on this a little bit because I sometimes can see transparently that it's just being used by local providers to block competition. And so they say, oh, you can only provide virtual services if you have a physical location in the province, et cetera, et cetera. And they do it. It's just straight up restraint of trade in some situations, but in other situations there are abuses. And I kind of back off it, and I think, well, bad actors are bad actors, whether they're physical or virtual. And the people who. So, Bill, you turned your mute off. You want in on this? Go ahead.
Yeah, well, I feel quite strongly about it. I typed an answer in the chat, but as an emergency physician myself, there's been a ton of stuff that's come out from ER doctors in Toronto, BC. There was a big article saying about how awful virtual care is, and it's flooding the emergency departments with, inappropriate patients. And I can speak from both sides. on this one, which is to say that, yeah, like you said, there will always be physicians, unfortunately, that cut corners and don't do a comprehensive assessment or exam, but you can't, you can control through that through, license. The solution is not to throw our hands up and go, well, just because of that, bad actors, you say we're going to regress from the 21st century and remove virtual care. Like, that's crazy. And both Alberta and Ontario, the CPSA sent out a notice that you could not practice virtual care unless you could refer to a specific in-person community. And they walked that back afterwards, actually, and said, well, if you have partnerships with other practices that you can refer to, that's also acceptable. It's not that you have to physically be the one to do it, because they recognize that, like, what about 50% of the population that lives in a rural community that can't get to, and our own doctors that are family doctors said, well, I'm going to rate the CPSA directly in my MLA to say this is ridiculous because I'm a family physician practicing care, and I'm helping folks in rural areas. So I think it's just a fine balance. That's all.
And we saw this validated in academic studies as early as 2014 in the early BC example, where physicians were complaining, GPs were complaining in one northern BC community about referrals to virtual care in the mainland. When it turns out, when the academics investigated, the time to first appointment was 7 to 14 days for urgent GP complaints, which of course is ridiculous. So what was happening was the virtual care was acting as a safety valve. My thought is that most virtual modalities, and Chris, I may go to you on this one, but most virtual modalities allow for audit trails to be created, right? I mean, when you create a virtual interaction, if you wanted to, the regulator could actually pull a clip. What do they say on the call centers? This call may be recorded for quality purposes. There's no reason why you couldn't record calls for quality purposes, is there? Chris, I'm going to you.
Oh, I wouldn't. I mean, technically, it's a tap-in. It'd be easy to do, obviously, and has interesting implications if you do that, obviously. So yeah, I think it could lead to greater transparency, not less.
I mean, you have, as an ICU doc, you have huge transparency with people looking over your shoulders and seeing what you're doing on a day-to-day basis. I think a lot of other colleagues in other specialties maybe have less transparency in their practice. Is that fair?
Complicated, I would say. Yeah. I mean, being in a hospital setting leads to some accountability that if you have, an individual practice in the community, then you might not have. So yeah, so I think that's a complicated effect.
Okay. Advice for students looking for jobs in this space. A couple of you have said you're hiring. Alex, advice for students?
In the digital health tech space?
Yeah.
It's an interesting question. What we're doing is somewhere between the old world and existing models are going bankrupt, in the new world where people are changing the world, and we're somewhere in the middle of all of that with old and new. I think if you can jump into something that you believe in that's growing, grab on for the ride, you're going to learn a ton. Being an entrepreneur is a unique experience. I love what some people have said about sort of, doing the founding and doing the management. I think being an entrepreneur has a different set of opportunities, challenges, and skills that people need, but you can get into a world that's really transformative like this. I think it's thrilling and you'll learn a ton. Work with great people though, find good people and work with them.
Sam?
Sorry. So I think lots of opportunity out there. Directly, you can reach out to me. The Rotman MBAs, we love Rotman MBAs. We have a whole group of them that have sort of come in serially at KeyOps. But I think also just reaching out within the community. I think we all know a lot of each other, and we know other people are hiring. So, connecting that way. LinkedIn is actually a really powerful tool if you go through that as well. and also connecting through Halo Health. So Halo Health just gets a huge wave of all the startups basically in the country seem to funnel through there, and they'll know who's looking to scale up or who just raised money and is probably hiring up.
Raising money is the cause and effect there is chat that I'm going to rephrase in my own way, which is, are you guys paying attention to what government's doing with its digital health projects? Does that world, Bill and then Chris or Sam, you're smiling, anyone who wants in on this, but are you tracking what government's doing? Does that matter and influence how you're going?
Sam, go ahead first if you want to jump in.
I'm not really in that space. I'm just sort of laughing because the government drives me bonkers when it comes to these things. But I think, Bill, you're more suited to this.
Well, I guess I'm trying to figure out, so what will means, like, can you maybe clarify when you say what the government is
someone
doing?
in the chat was asking if the world would be a better place if there was all one digital health system and things got together. I after working on that for 20 years have stopped worrying about that. So I was kind of wondering what you were thinking about and how government initiatives do change what you're doing. Like, are you watching how the digital health world unrolls in different provinces? Does that guide where you're making your investments or what you're thinking, or is it just the fee codes that you care about?
No, yeah, definitely. And so I think the sort of way I've seen government work when it comes to healthcare is on a very large basis where, we have a fantastic system that's a single payer that allows for all folks that are, have access to that insurance to seek care, which is basically every Canadian. And so, it's a amazing system that we, having taught and worked in various countries around the world, being in Peru now as well, and worked in the US, like I can tell you, I really envy our system in Canada. I think we have a great model of care. However, what it doesn't do really well is foster innovation in the digital technology space or just healthcare, private industry in general, as it sort of engages with government. And so the thing I like to remind folks of is that we have a publicly funded, privately administered system of care in Canada. And hospitals have independent boards of directors. You want to build a hospital, you got to get 50% fundraised from the community and then 50% chipped in from the government. Like it's very much privately engaged, but what that tends to happen is that funding will go from the government to a select couple of winners in the system, rather than have a branch, I think, that's specifically tasked with innovations where they can put funds into different activities in private industry to see if it can grow and then partner with the government ultimately to improve access to care. So, the US Centers for Medicaid and Medicare has the Center for Innovation that can do that. And then if it shows cost reduction, it can be expanded across the entire country very quickly based on the Affordable Care Act, how that was implemented. So I think I'd love to see something like that in Ontario and in different provinces.
So not picking winners, but creating an environment and then picking winners? I didn't really understand. Isn't scaling a particular company picking a winner?
I think it's that there is not, at least to my knowledge, maybe I'm not aware of it or something, but maybe that's also a sign of, you got to kind of know people. You got to be in order to get that initial investment from the government to even try something, you have to already be extremely well established, I think, or have some kind of connection in some way. And so it'd be great to see more opportunities for funding by government for innovation, if that makes sense.
I think the feds think they're doing some of that through I can't keep them all straight. I think it's called IRAP, and some of those programs where they do early stage. And I've been involved with some of that at Women's College and been actually reasonably impressed by how light touch it is. I don't think it comes with a lot of money, but it's not big money the way that some of those programs are. Chris, anything on this one?
Yeah, I would say as an early stage startup, government tends to operate at a scale that's way too big for us and operate in time scales that are too long for us. I mean, an early stage startup, you're looking for your next contract, the next client that you can sign up as you're rapidly like iterating your product. So we don't pay attention to the macro trends so much. We are interested in micro trends. Like if there's test of change funding through Ontario healthcare teams, that's of intense interest because that could drive approximate contract. So you are engaged at a micro level. The one thing that I do think is helpful is easy to access funding in small amounts. You know, so if government has programs that give $200,000 or $400,000 for a little company, that can be transformative. And having more access to that kind of capital in a non-bureaucratic way, I think can salt the system so that you can grow up and sort of get to the next level.
Well, Will, we've been a beneficiary of that. So we've received funding from IRAP and we're totally not the right fit, but we found a champion who gets us and believes in us. And it is, to Chris's point, it's a game changer. Like for where we are, to get a couple $100,000 is huge. And it's outside of the weird government bureaucracy with like a 40-page form to apply for $10,000. It's like, not doing that. So they know what they're doing. You got to move it earlier into the pipeline so people can access it a bit earlier. And you've got to have flexibility to be able to support a lot of innovation. And some of that's going to yield dividends.
Yeah, although it's interesting, Alex, because of course that gets you to a certain point, but it doesn't solve your fee schedule issue, which is often impenetrable. So this, the scale issue for many of the companies that I've worked with ends up being somewhere in a fee schedule setter place that is not at all transparent to the outside world, which I get, right? Like those negotiation processes are brutal. But I agree with you. I think the feds have done a decent job. And I didn't mean, for my friends on the line who are in the government world, I'm sorry, I didn't mean to be quite as caustic as I was. I do understand that people are doing the best they can with what they've got. I think I just want to close and see if anyone has any final shots on any final shots for the audience on anything that we've talked about today. So that was pretty lame, I have to say. But does anyone have any final shots? Okay, well, seeing none, I'll just continue my lameness because I lost 3 more participants with that lameness. And thank the 4 of you, and thank the Sandra Rotman Center again. You 4 have been great. I'm so excited about the journeys that each of you are on and your companies, and I look forward to seeing the great things that you achieve over the next several years. So good luck to all 4 of you and your teams. Thanks very much, and thank you everyone for joining us today.
Thanks so much.
Thanks, everyone.
Thank you.
Have a good night.
Bye.
Bye, everyone.
Bye.
I got a little lame there at the end. Sorry about that.
That's okay. Everybody's still here on the webinar.
Oh, that's okay.
Listening to that.
That's okay.